Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Gerard Sanacora will present Crossing the Goal Line, Bringing Ketamine Treatments to the Clinic. The Brain and Behavior Research Foundation funds the most innovative ideas in neuroscience and psychiatry to better understand the causes and develop new ways to treat brain and behavior disorders. These include addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, obsessive-compulsive disorder, post-traumatic stress, and schizophrenia. Since 1987, the Foundation has awarded more than $394 million to fund more than 5,700 grants to more than 4,700 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists. I'm delighted to introduce Dr. Gerard Sanacora. Dr. Sanacora is Professor of Psychiatry at Yale University School of Medicine, Director of the Yale Depression Research Program, and Co-Director of the Yale New Haven Hospital Interventional Psychiatry Service. He is a member of our Scientific Council and was a Foundation Distinguished Investigator Grantee in 2014, an Independent Investigator Grantee in 2007, and a Young Investigator Grantee in 2001 and 1999. Today's webinar will begin with Dr. Sanacora's presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Feel free to submit your questions throughout the presentation. Following the presentation, I will ask as many questions to Dr. Sanacora that time will allow. And now, I'm pleased to introduce Dr. Sanacora. Jerry, the floor is yours.
Thank you very much, Jeff. I hope that transferred okay.
Yes.
Thank you. It really is my pleasure to have the opportunity to do this webinar. This is really kind of the dream of a translational neuroscientist to actually have a treatment that actually makes it to the point that we can help patients. And it's a rare opportunity for many translational neuroscientists, but this is one that has actually come to fruition. First, I just want to talk a little bit about, I do consult with many companies, and this is all my disclosures. You can read them here. That'll be posted. Also, I just want to go through the topics. What I wanted to discuss a little bit is the history, and really to highlight how it really was basic science discoveries and understandings of brain function that brought us to the point of trying ketamine, or brought the field to the point of trying ketamine. Then to highlight some of the early clinical evidence suggesting ketamine's antidepressant responses, and then really to highlight what I think are the key clinical questions that still remain or are being answered as we are talking right now. There are so many studies coming out that we're starting to learn so much more about this treatment really on a weekly basis. And then at last, just to talk about, how we can move forward to responsibly bring this treatment to patients. So to start with, is the question that we should be asking is, do we really need another antidepressant? There are over 24 already FDA-approved antidepressants on the market. Was there really a need for a new antidepressant? And I don't think I have to press this point too hard. I think pretty much everybody would agree. Simply the fact that depression remains one of the major contributors to the global burden of disease, the fact that suicide rates, unfortunately, are still increasing in our country, and third, as highlighted in this figure from the STAR-D study, a large percentage of our patients are not really receiving an adequate response from the current antidepressant medications. And unfortunately, even a large percentage of them that do go on to have relapse. So I think there's very little argument based on those three that there's a need for medications. But also, even when a patient is going to have what we would consider a response, meaning a 50% improvement in their symptoms, it typically takes about 6 weeks for half those patients to get there. So the fourth real point here is even our medications, when they do work, typically have a long lag time, which can feel like eternity to patients when you start somebody on a new medication and tell them, this will help, but you have to stick with it for 4 to 8 weeks before you're going to see that benefit. With that, it's always been the Holy Grail in the field to have an antidepressant that can have a more rapid onset of effect. So this is a paper that I just chose, only going back from 2001, not that distant in the future, where you can see right up in the beginning, practicing clinicians know that mood-elevating effects of antidepressant medications usually take about 1 to 2 weeks after initiating to see anything. And at the time, that was just accepted. That was less than 20 years ago. And then you see from the last sentence, this rapid onset of activity would be one of the characteristics of an ideal antidepressant. However, no drug appears to work more rapidly than any other, and the time course is generally prolonged. So this was only 20 years ago, less than 20 years ago, and it was just accepted that that was the case. I think one of the biggest breakthroughs, or one of the most important things that the ketamine research has added to the field, beyond offering hope and optimism to individual patients, is it really rejuvenated the field with this idea that we can develop treatments that have a rapid onset of effect, and we can develop treatments that don't primarily target the monoaminergic neurotransmitter system as antidepressants. So the field is now replete, and I'll go through some of these other drugs a little bit later more carefully, but there are several drugs with similar but slightly different mechanisms that are all now being developed with the hopes of having other rapid onset antidepressant. All right. So quickly, what was the rationale for actually trying ketamine? So where did the idea come from? And this is actually from a recent paper. John Crystal and Dennis Charney, who were really two of the people that ran that original study back at the VA hospital at Yale. Really, the idea came from the change in the thinking about the pathophysiology. The existing thought had really been that there was some dysfunction in the monoaminergic system, largely in the raphe nuclei, that was leading to depression in predominantly either serotonergic or noradrenergic abnormalities. The change came from years of studies really having difficulty showing those abnormalities, and also from some inconsistency in the findings, the lag time to onset of effect, the fact that there seemed to be more and more increasing evidence that will show that the cortical and the limbic regions seem to be very much involved. So it was really with this basic understanding that is it possible that there really is more cortical or limbic abnormalities, which were largely controlled by the amino acid neurotransmitter systems, GABA and glutamate, and that might be a more effective way of targeting these. And this is a quote from John and Dennis. So, and let me just tell you a little bit about what the climate was like at the time. So this was right at the time when the seminal paper by Wayne Drevitz came out showing that there truly was abnormalities in the cortical regions of depressed patients, similar studies showing hippocampal reduction in depressed patients, and cytoarchitectural changes, such as deficits or reductions in glial cells in several brain regions, cortical brain regions. So there was real evidence now that there was some structural abnormalities, and they were present in the cortex and in the limbic regions. And there was also increasing data and new studies coming out to suggest that glutamatergic pathophysiology is likely to contribute to depression. And a lot of these studies came from models using stress or chronic stress and seeing the effects of stress on the glutamatergic system and how that could contribute to depression. So studies by Bruce McEwen's lab, Rob Sapolsky's here, showing the effects of glutamate can actually be toxic at certain points. Work from Bita Mogadam's lab actually showing that acute stress can have very rapid and dramatic effects on glutamate neurotransmission and release, and then starting to understand the actual mechanisms of how that could occur. With understanding the role glutamate can play, both in the pathophysiology, but also in controlling some of the neuroplasticity, we started to learn at the time a lot more about how glutamate modulates neuroplasticity. And that really was the thinking behind targeting the NMDA receptor as a mechanism of modulating the glutamatergic neurotransmitter system. So I showed you before a very nice quote from John Crystal and Dennis Charney, really highlighting that point. I would be remiss not to mention that for the decade prior to that, Phil Skolnick had been doing a series of studies at the NIH where he was able to identify changes in NMDA receptor function to be associated with various forms of stress, and also identified the potential for these NMDA receptor antagonists to have antidepressant-like effects. So this was the climate that existed in the late 1990s when that original study was done using ketamine. And as it really said, it was the idea of could we probe, or it was actually could science probe, but it was really the group of John Crystal, Dennis Charney, Rob Berman, and others had the idea is it possible to use ketamine just as a probe at the NMDA receptor to see what would happen. And here you could see what has become an iconic figure, that very rapid onset of antidepressant effect reflected by the change in the Hamilton Depression Rating Scale within 4 hours that continues over 3 days, compared to the weeks when patients would get placebo, a single dose of 0.5 milligrams per kilogram ketamine. And you can see another quote from there. To the amazement of our patients and ourselves, this was a quote from John, ketamine produced that rapid, profound, and surprisingly durable antidepressant effects. So at the time, the investigators really had the idea that this could have an effect, but I don't think anybody had the idea that they were going to see antidepressant effects within hours. And I don't think anybody had the inkling that they would see antidepressant effects that lasted well beyond the duration of the drug's presence in the body. Remember, ketamine is relatively rapidly metabolized, for the most part is cleared. And if you look at the acute effects of ketamine on cognition and perception, cleared within an hour to 2 hours at most, but seeing these antidepressant effects that went on and were sustained for days after it. The interesting thing was that finding came out in 2000, the publication. It wasn't until 6 years later that it was actually replicated. I think in large part because this was done by a bunch of academicians, and most of us in the field, after seeing those original findings, went back and tried to figure out how it worked instead of just simply replicating and convincing ourselves that this was a replicable finding. But in 2006, Carlos Zarate and Dennis Charney were able to replicate the findings almost identically with a slightly larger group of patients. And here showing that about 71% of those patients met response criteria, meaning a 50% improvement at 1 day. And you can see all the way to the right of that graph where that compares to 8 weeks of treatment with standard antidepressants like venlafaxine, bupropion, or an SSRI. Since that time, there have been many replication studies, and it remains one of the most consistent findings in depression. And this is just from the APA Council of Research Task Force publication from about 4 or 5 years ago, where at the time they were able to do a meta-analysis and show an odds ratio of about 10 compared to placebo at 1 day after treatment, and even an odds ratio of greater than 5, meaning the chances of having a response 5 days chance of having a response 7 days after getting the treatment is 5 times greater if you got the active ketamine versus a placebo. That is an incredibly high odds ratio, especially after a single dose, and especially after the drug has been metabolized and long gone from the system. But these studies generated great interest, and the media, the national media and the international media picked this up with very positive reports, really highlighting the potential and the optimism that these studies brought to the field. And very rapidly, clinicians started to offer the treatments. And this was from a survey that we did about 3 years ago, asking clinicians that we identified who were providing ketamine, either academic clinicians or private clinicians that were providing ketamine treatments. And you can see how rapidly that growth occurred. And I can tell you, if you go out 2 more years or 3 more years where we are now, that curve continues to grow at that same rate. But this was a very unique situation. This is a situation where there was great hope, and there really was very strong findings that there was rapid onset of antidepressant effect in patients who had not responded to standard treatments. But in relative terms, there was very scarce data, especially on the longer-term efficacy and safety. So we were placed in kind of an ethical and complicated situation where we had a treatment that had an FDA indication since 1970, but as an anesthetic. Millions of people have been exposed to this drug, but usually on a single term in an operating room. But now, having this extremely promising data coming out, at least showing a rapid onset of effect in the short term, but a true dearth of information on the longer term efficacy. And that led us, again, through the APA task force to try to put together some consensus statement. And really the main thing at that time, and this was really only 2 years ago, the main thing that we came to agree upon is there really wasn't enough information to provide very good recommendations. We knew a lot about what we should be looking out for, but we really didn't have the data we needed to suggest how this treatment should be delivered, how frequently it should be delivered. And this really was an important point in the clinical treatment when we realized there were a lot of questions we still had unanswered. So what I'd like to try to address in the next few minutes is really to go through at least what I think are the remaining questions. And as I mentioned, in the last few months, we're actually starting to answer many of these questions at a very rapid pace. So the big questions that I think remain, especially the clinically relevant ones, are what are the optimal dosing strategies? So that first dose that was chosen of 0.5 milligrams per kilogram given over 40 minutes was chosen purely because that was the dose that had previously been used by the investigators to study the psychotomimetic effects of the drug. So in a dose that would have people experience changes in cognition and perception, but still remain awake enough to report it. That was the rationale behind that initial dose that was chosen. Nothing specifically related to antidepressant effects. So is there ways of optimizing that? Is there ways of optimizing the route or the frequency? What about the longer term effectiveness? Most of those early studies, in fact, all of the other studies that I mentioned to date, was just a single dose and only looking out for a week. Really no evidence suggesting longer term benefit or longer term safety. And then finally, what are some of the major modifiers or moderators of the response? We still have to learn. Are there specific drug-drug interactions that we need to worry about? Is there specific subtypes of depression or genetics or endophenotypic groups that are more likely to benefit or to have adverse effects? So we have a lot to learn. Or is there certain behavioral interactions that we should really be aware of? Those I see as the immediate clinical concerns that we need to address. On the longer term, it would be very helpful for the field to have a much better understanding of the mechanism of action in order to allow us to better develop new treatments that may not have some of the same risk and concerns that come along with ketamine. All right. So to start with, what is the optimal dose and optimal dosing strategy? It's a little bit more complicated than we may think. As I mentioned, that first dose was really a serendipitous choice because that was a dose that got those psychotomimetic-like effects, but the patient stayed awake enough. But a very interesting study that gained a lot of attention, a study by Ron Duman's lab in Science, where he showed the downstream mechanisms that were associated with ketamine, also showed that there was an inverted U dose-response curve. So if you actually looked at ketamine and you went from what's called a sub-anesthetic dose of about 10 mg per kg in a rodent up to 80 mg per kg, which is now an anesthetic dose, you lost that antidepressant response. And the response, the actual forced swim test, is done 24 hours later. So, it's long after the anesthetic effects are worn off. But very interesting where the lower dose had the effect, if you went up higher, you lost that effect. And then the lab was also able to show that the changes in cellular functioning, so this is actually phosphorylation of the peptides that are critical in generating some of these downstream effects, you can see a dose-response curve with gradual increases up to 10 milligrams per kilogram, but going up to 80 mg per kg, which again, that anesthetic range, that effect, that cellular effect is lost. In my lab, we were able to actually use another type of technique called magnetic resonance spectroscopy, C13 MRS, to look at the rates of glutamate and glutamine cycling. And we could show a very similar dose-response curve, showing that at the sub-anesthetic doses of 1, 3, 10, up to 30, we see this increase in the rates of cycling, but then going up to that anesthetic dose again, that was lost. And we were able to replicate that same behavioral effect on swimming, on the forced swim test, a day later. So it really did show some evidence that there's what we would call an inverted U curve, that just going up higher isn't always better, that you can cross this threshold where you lose the effect. And interestingly, that matches work that had been done 20 years earlier by Bita Moghadam's group using microdialysis, showing that sub-anesthetic doses of ketamine, either 10, 20, or 30, produce this increase in glutamate efflux. This is really the glutamate that is spilling out over the synapse and is able to be taken up and measured. But when you go to these higher doses, you actually lose that effect. And this is really just a twofold increase. Going from 30 to 50, you lose that effect. So it really does suggest it's what we would call a very narrow therapeutic window, at least in terms of having the effects on cycling and cellular changes. But does it really matter in the clinic? That's one of the biggest questions we still have to face. I also, using that same C13 method, we were able to show the time dependence. So there was a dose dependence that I showed you on the previous slide, but here we could show that after a single injection of sub-anesthetic ketamine, we get a very rapid rise in glutamine labeling. And this is really reflecting the turnover of glutamate and glutamine. And we'll talk a little bit more about that later. And we see it happen within the first 15 minutes. By a half hour, it's decreasing. And by an hour, it's actually gone. And then importantly and interestingly, at the time when we actually do the behavioral measures in these rodents, 24 hours out, we don't see that effect at all. If anything, there's a trend towards going the other way. So it really does suggest that if this is involved in the mechanism of action, it's just something that kicks off the cascade of events that then have an independent process that it follows. And that would be in line with what we see, the fact that the drug is metabolized so rapidly. We see the effects long after the actual drug is gone. So what about dosing in the clinic? Well, surprisingly, we have very little data on this. After now 20 years of studying these effects, there isn't a dramatic amount of evidence for dosing. What I'm showing you here are the results of a collaborative study, the RAPID study group, where 4 doses of ketamine was compared to midazolam. So as I said, the 0.5 milligrams per kilogram was the original dose that was chosen. But this studied much lower dose of 0.1, a dose of 0.2, the original dose of 0.5, and then doubling that to 1 milligram per kilogram. And then looking out over time. And this is just looking at the HAM-D6, a subscale of the HAM-D, which was the primary outcome measure. Overall, ketamine showed a beneficial effect over midazolam at day 1 and at day 3. At day 1 very clearly. But if you look at the individual doses, the 0.5 numerically looked the best. We didn't have enough power. There was only 20 patients, around 20 patients in each group. So we really weren't powered to say with great confidence that one dose was superior to another dose. But I think it is interesting to look at the dosing that the 0.5 and the 1 mg per kg did generally well. Interestingly, the 0.1 and the 0.2 were flipped from what we may think. And I'm not sure that's a real finding or if that's just the fact that we have small numbers. But if you look at the full MADRS at day 3, when was the only time it was measured after initiating, you really see that it's the 0.5, the 0.5 milligrams per kilogram that has that very large effect. That effect size with and the magnitude of the decrease in the depression severity score. And again, the 1 mg per kg is pretty close, but it really doesn't look like there's a huge benefit, if at all, in increasing the dose from 0.5 to 1 mg per kg. Yet there was a very large increase in the side effects. So the next question is, what is the optimal dosing frequency? This is a completely unique drug. This is, all the other drugs that are used for depression, we pretty much want to keep the plasma level as constant as possible to keep that drug, on board at a steady state. This seems to be very different, but nobody really knows how it should be dosed. If we think that it initiates an event, but that it gradually will wear off, when should we dose again? And to date, the best study that I'm aware of that looks at this is a study that was actually sponsored by Janssen Pharmaceuticals, but using racemic ketamine IV, just like all the other studies. And this looked at comparing twice-a-week treatment versus 3 times a week treatment to see if it would be better to dose 3 times a week, similar to what is done for ECT, or just twice a week, based on, it looked like the peak effects was lasting about 3 or 4 days, about 3 days with the treatment. And you can see this study, which randomized patients to either receive 2 or 3 times, and then within that group, randomized them to either receive placebo or ketamine. Very nice effect with the twice a week, also nice effect with the 3 times a week, but really no evidence that there was a benefit to dosing more frequently. And if you look at the responder-remitter rates, really no evidence at all to suggest more frequent dosing was beneficial. And based on these studies, Janssen moved ahead with their protocols to use that twice-a-week dosing, and it also seems to be what many people in the community have moved toward. So again, this is data from that survey that we conducted, where we got data back on 54 providers around North America who were offering ketamine, and asked how many times per week were they treating patients. And this data probably reflects, we estimate about 3,000 or more patients. So this is a lot of patients that this data comes from, but this is just from clinicians reporting to us. And you can see very typically in this frequency diagram, the majority of people were dosing their patients about 2 or 3 times a week. And again, this was about 3 years ago we collected this data. Interestingly, we asked them, well, if people do respond, how frequently did they have to come back to get more to maintain that response? And this was interesting in the fact that you can see there's a spread in the frequency distribution, but the large majority of people are reporting either about 3 or 4 times a week. Either about once every 3 or 4 weeks, the patient would come back. So again, patients who have had a good response to an initial treatment, we ask the clinicians, how often do the patients typically have to come back to maintain that response? And they were reporting to us that on average, their patients were coming back about once every 3 weeks or once a month. So at this point, we did not have a large amount of high-quality data. Even that survey that we conducted was actually from a large number of patients, but this was not systematically collected data, and we were really just relying on clinicians' reports. But if we look now, things are changing very rapidly with the introduction of esketamine. So I'll just quickly explain what we have been talking about is ketamine, which is the racemic mixture, which contains both the S and the R enantiomers of ketamine. When we're talking about esketamine, we're talking about the isolated S enantiomer. So really, esketamine is part of the total racemic ketamine that was discussed in the previous studies. The reason esketamine is interesting is it has a much higher affinity for the NMDA receptor. Remember in the beginning I started talking about this idea that targeting the NMDA receptor could be a way of generating this rapid onset antidepressant effect. So esketamine has a much higher affinity, which means it has a higher potency at the receptor, so you can use lower volumes to get the effect. And that was shown with an IV study by Jazz Singh and others that was published, showing that you can in fact give relatively low doses of 0.2 mg per kg, and I showed you before 0.2 mg per kg had intermediate effects, where here it appeared to be very good effects, and really did not see much of a benefit going to the 0.4 mg per kg above the 0.2. So it did suggest that you could use a lower dose and get the same effect. Since then, Janssen has developed esketamine in the intranasal formulation, and I'm sure many of you, if not all of you, have heard that that has recently received an FDA approval for the indication of treatment-resistant depression. But we'll go through some of the data that got that to the point. So this was one of those early studies just looking at multiple doses. And again, this covers a few things. One, it shows that the intranasal formulation of esketamine did have the antidepressant-like response compared to placebo, but it also showed that consistent trend towards some type of a dose response, especially if you look at remitters with the increasing dose, at least up to 56, showing some benefit over 28, and then between 56 and 84. In this study, visually, there may be some statistically, obviously not enough power to say anything with great confidence. But then Janssen has went ahead with a large phase 3 development program. And I do want to take a few minutes just to really explain that, because now these are the studies that really inform the FDA in making their decision, and really should be what clinicians and patients are thinking about when they're considering if this is appropriate treatment for them. So these were the 5 phase 3 studies, and I'll go through each of them at a very cursory level. But really, the first 2 were in general adult populations, either using a fixed dose or a flexible dose over a month, twice a week for 4 weeks. The third study is in an elderly population or over 65. And then the last 2 have to do with maintenance. And we'll go through that. But now you can start to see the sample sizes. So now we're up to significant numbers of patients. No longer are these studies of 18 or 20 some odd patients. Now we have numbers well into the hundreds. And if you look at the maintenance studies, we have over 1,500 people in these studies. And in some of them are exposed to the medication for over a year or for up to a year in the study. So now we have a lot of patient years to really start to consider the efficacy and safety, or the longer-term efficacy and safety. This just outlines the general part of these studies, the general design. And I think the important thing to consider here is that these patients had documented non-response to 2 treatments. In fact, one of the treatments actually had to be witnessed, but documented response to non-response to 2 treatments. And then the patients were started on a new oral antidepressant at the same time they were started on the esketamine or placebo. So this is a bit of a unique design. It's a design where it really isn't testing the treatment, the esketamine in this case, against placebo. It is testing the new treatment, the esketamine, plus a new oral antidepressant versus placebo plus a new oral antidepressant. So everybody in these studies were getting new oral antidepressants. So it's a little bit different than when we think of most studies that are randomized to placebo. And this is the result of the first, the 3001, and this was the fixed dose, either 56 or 84 milligrams. You can see the sample sizes, about 100, a little bit more than 100 patients in most of the arms. So there's 2 big messages I try to highlight from looking at this is, one, under these controlled conditions, even patients that are previously treatment non-responsive. So based on the STAR-D study, you would expect the treatment response, especially remission rates, to be relatively low for these people that have not responded to 2 oral antidepressants previously. But here we're starting to see, even with just the addition of the new oral antidepressant without the addition of the esketamine, we're getting decent clinical responses. I mean, we're getting up to 15-point drops in the MADRS over a month. But both doses of the esketamine added to the oral antidepressant at every time point showed numerically lower scores. So in other words, a greater improvement. However, the statistical model used here did not provide statistical significance. So the addition of esketamine to the oral antidepressant did not separate. Very, very close. And if you looked at them individually, without weighting, that there were effects, but combined with the model used, not meeting the effect. But if you look at it other ways, if you look at response, remission, the totality of evidence is pretty clear that both doses of the esketamine added to the oral antidepressant seem to show benefits. And now you're looking at response rates over 50% and remission rates coming up on 40%, which is quite good for what in the STAR-D study you would expect about a 15% remission rate in this group. This is the second study, the Transform-2, which again was the same study design, but in this case it could be flexible dosing between 56 and 84 based on what appeared to be better for the patient. And this, again, you see a very similar pattern. Here, the statistical significance on the primary outcome measure as determined a priori was met. But again, a really nice response. And I think this is important to realize because I think this shows that the level and the intensity of care that's provided within this protocol has its own antidepressant effects, but that the drug has benefits on top of that. And again, if you look in terms of remission and response rates, it's actually very impressive here. Seeing almost 70% response rates at the end of the month and over 50% remission rates with the esketamine added, but not so bad even without the esketamine, much higher, about twice the remission rate that you would expect based on the STAR-D. So I really think there's a dual component. I think the medication has its unique effects, but I think the regimen and the rigor of this treatment protocol has its own antidepressant-like effects, especially when it is used with a standard antidepressant. This is to highlight the long-term efficacy of the study. So this was the 3004 SUSTAIN-2 study, And in this case, people either came in through one of the randomized studies or entered directly, and they received that 4-week treatment. And you can see a very nice drop. This would be considered during the induction phase, where there was about 78% responders with nearly 50% remitters. But of those that were considered in response were able to continue receiving the treatment. And you can see that there really wasn't much change. And the treatment continued at once a week for the first month after the induction, and then it went to either once a week or once every other week, depending on how the patient was doing. So when you start to average large numbers, you can see it was a good effect without much change over time. So it looks like the antidepressant effects could be maintained. Now, obviously, when you look at individual patients, there's variability. So not everybody, hits a MADRS of 10 and stays there. There's variability, but when you average over the large group, there is good evidence that for many of the patients, the response can be maintained. The next study actually gets to the question about, but what if you stop? What if, and this is a randomized withdrawal study. So here, the groups are broken into two. So all of these patients were responders. But now you look at patients that were responders to an initial treatment and then 3 months or a total of 4 months on the medication. So responders means they were at least 50% better, but remitters were to the point that they had almost no symptoms as measured here. So they were broken into two different groups. And if you looked at the people that were stable remitters, you could see that stopping the medication did have an effect of increasing the likelihood of having a relapse. These are survival curves. I'm not sure if you're used to looking at that, but the blue line here is the group that was randomized to the oral antidepressant, but then they were shifted to placebo after having a response on the esketamine. And you can see that over the first 2 or 3 months, there's a pretty dramatic drop-off, meaning about 30 to 40% of the patients did relapse. You can see a much slower rate of relapse if patients stayed on the medication. But even a bigger effect is seen if patients were responders but not remitters. So in other words, if they had at least a 50% response, but they still had some residual symptoms. Here you can see that upon withdrawal of the esketamine, a rather rapid, not within days, but a return of symptoms over the next few months, with a greatly reduced likelihood of that happening in the patients that continued to receive the esketamine nasal spray. So now we're starting to look at a treatment that is probably not short-term, meaning this is not what we originally were doing, one treatment and seeing how it happened, and then we went to a series of 4 or 8 treatments. Now we're looking at least a substantial subgroup of these patients are likely to be receiving treatment going at least for months. And the question really becomes, is it safe to repeatedly dose ketamine? And we do know that there are some short-term risks associated with ketamine treatment. One is the physiological effects. We know there are changes in the cardiovascular demand. We know typically we see increases of systolic blood pressure and diastolic blood pressure shortly after receiving ketamine that can last for about an hour or 2 after the dosing. And sometimes it goes up to levels that could be clinically concerning, meaning over 180, over 100, or 110 beats per minute. Where for many of us, that would not be a major life-threatening event, but for people whose cardiovascular system may not be able to sustain that challenge, it could be a very important and serious adverse effect. We also know that there are psychological effects, and this is actually some of the data, those original studies done by John Crystal that I was mentioning, how the dose was chosen, showing that there is pretty dramatic effects on cognition, perception, and acute anxiety with a dose of 0.5. With a dose of 0.5 milligrams per kilogram. And it's something that does have to be managed. On the longer term, there's preclinical data from animal models suggesting that ketamine, especially when given chronically, frequently, or to very young organisms, can have detrimental effects on the brain. So the question is, do we see any of that in humans? Some of the best data comes from patients, not from patients, but from individuals with ketamine use disorder. And many of these studies came out of the UK from Celia Morgan, showing that frequent use of ketamine is associated with several different effects on the brain. Some structural changes are occurring, some changes in memory. Again, we don't know. These aren't prospective studies. These were studies looking at patients who frequently abused the drug and showed evidence of these changes. We don't have a baseline to show that it's a cause and effect, but they were highly associated. But interestingly, less frequently used or less frequently abused ketamine did not show those same changes. So we're really faced with this idea of trying to understand where that line is between relatively safe administration to levels that could be creating some toxic effects. The good news is at least the short-term treatments with ketamine, where we've done neurocognitive testing, a few studies, one from University of Minnesota, another one from Mayo Clinic, and then from our own group and a group from the UK, really haven't been able to show any effects of dosing for up to 2 to 4 weeks with ketamine. So dosing usually either using 4 to 8 treatments of ketamine, really not showing any benefits on a battery of cognitive tests. If anything, slight improvement in some measures, but clearly nothing that's setting up any red flags. In our own experience at Yale, we started offering ketamine clinically in about 2014, largely to patients who were not able to participate in any of our clinical research protocols for one reason or another. And the large majority, as you can see, these patients were hospitalized or had previous suicide attempts, and many of them had previously tried ECT and were non-responders. So these were patients we really didn't have many other options. And with ketamine being available, we were able to offer them this treatment. And you can see our experience here. Overall, we really had no major effects on cognition. Going out, and some of these patients had received well over 2 years of treatment. So, and the response rates are right in that range of about 50%. And remember, many of our patients, in fact, in this case, half of our patients had already tried ECT, and the majority of these not had a good response, and that's how we ended up treating them. So we started to see some benefits going over the long term in a small group of people. But again, now we have much better safety data with esketamine. That large study that I showed you where patients were treated going out over a year, we can see that there are definitely treatment-emergent adverse effects, but for the most part, they're fairly tolerable. The most common things that we do see are complaints of dizziness, the dissociation, and again, we see about a quarter to about a third of the patients experiencing that, experiencing those symptoms. Nausea, again, about a quarter of the patients at some point. Headache we see, but to be honest, in the placebo control things, we also saw a fair amount of that. There definitely is some somnolence that's related. Some dysgeusia, which is actually a strange taste, alteration of taste. And a small percent, but a substantial percent of patients do have some vomiting and nausea. So in general, this is a treatment that clearly has some side effects that needs to be managed. But for the most part, patients are able to tolerate that, and that's reflected by the very low dropout rate. So the adherence to these protocols are all very high, going out up to a year. Some of the more concerning points, I forgot to mention that beyond the concern for neurocognitive impairment with ketamine misuse, there's also many reports of ulcerative cystitis, actually problems with the lining of the urinary bladder in people that frequently misuse ketamine. Fortunately, there were no reports of this in these long-term safety studies. There was no evidence of interstitial cystitis, which is a relief to many of us. In terms of blood pressure changes, there clearly are, and on average, there's a bump in systolic and diastolic between 5 and 10 millimeters of mercury. That is usually not a major issue at all. But what worries me, and what should worry most of you, is those rare patients that actually do have bumps into the more clinically relevant range. And you can see it's relatively small percent, about 4% of patients had a bump into that range, but it's enough that still warrants clinical observation, especially to any patient that is in any way at risk. Dissociative symptoms, they definitely exist, as measured by the CADS. They tend to hit their peak right about 40 minutes, and this is with esketamine. It's very similar with IV ketamine, but they always dissipate, and usually by an hour and a half, by 2 hours, almost always completely gone. And then the rest of this is not so important. The other thing here is the cognitive symptoms. So in these studies, looking out over the year for the patients that were going out that far, really no evidence of any impairment at all, which is very comforting to us. These are still, now we're talking ends of 600, 800, and we're starting to put together many patient years here, but still, I think it requires some level of caution as we start to treat more and more patients. Remember, pretty much all of these patients had to be healthy prior to coming into the study. One of the things that we're very interested in at Yale, and this is work in large part led by Sam Wilkinson, is the ability to use other treatments, ancillary treatments, to either reduce or maybe help people transition off of the esketamine. This is just a proof of concept study, a small study for feasibility, showing the ability to use cognitive behavioral therapy. And this was only after a 2-week treatment, twice a week for 2 weeks of IV ketamine, showing that the patients here in the blue line, the patients that actually have a good response, can maintain that response with cognitive behavioral therapy. That was started at the same time as the ketamine. But patients that really didn't respond to the ketamine didn't really have any added benefit to the CBT. In fact, they tended to go back to their baseline levels. But we're very interested in developing this and moving this further. Based on the neurobiology, which I'm going to talk about a little bit more, we think this could be a very promising avenue. Just to move quickly, who are the appropriate patients? Well, the question is, does gender or sex matter? The reason I bring that up is there are several preclinical studies that suggest it may play a prominent role in moderating the effect. I can tell you from the clinical data, at least the clinical reports that are out there, there hasn't been any consistent evidence suggesting that. And the one study that specifically looked at this was a sub-study within the RAPID consortium that I mentioned before, a study by Marlene Freeman, really did not show any differential effect between men and women with the treatment, the single dose. The other question is, what about anxious depression? We have evidence that suggests our standard antidepressants may not work quite as well in patients with high levels of comorbid anxiety. At least again in that RAPID study, looking at it, we really didn't have any evidence to suggest that anxious patients responded any less well than the non-anxious patients. How about age? That's one of the questions that I'm asked quite a bit. Again, that's been pretty tricky. So with esketamine, Rachel Oakes-Ross ran the 3005 or the Transform 3 study, which was for patients over the age of 65. And it does appear that overall there's a blunted response, not the same magnitude of effect, neither to the placebo plus the oral antidepressant or to the esketamine plus the oral antidepressant. These findings are really fairly unique. There's a greater separation right at the end. It's a little difficult to fully wrap your head around what the meaning of this is. But I think if you look a little bit more at response and remission rates, you see that there does seem to be an effect, again, lower than what we saw in the adults under the age of 65. But there does seem to be some benefit, at least for some of these patients. And we're working hard now to try to understand, what is different in the elderly group and what defines that. Because obviously it doesn't appear to be everybody it doesn't seem like the drug stops working the day you hit 65. But it is good to understand what's different about this group. All right. And how about suicidal ideation? We're just getting ready to wrap this up. So this was a study that we did in collaboration with every other group that had run a single dose study up to about 2016, who generously shared their primary data right down to the patient level, so we could understand how the suicide item changed after a single administration of IV ketamine. Because a lot of the patients in these studies didn't have any suicidal ideation to begin with, so it's hard to measure change if there wasn't. So having this individual patient-level data, we were able to do a meta-analysis and an analysis looking at those effects, and could see very, very nice and large effect size within 1 day, both in terms of the actual drop in the suicidal rating, but probably even more importantly, in the proportion of patients who reported that their suicidal ideation was gone, and right about 50% at day 1 with the ketamine compared to the controls, which hovered around 20, 25%. So very good evidence. This was followed up by a phase 2 study with esketamine, which showed a nice overall benefit and antidepressant effect going out over the first 24 hours, and you can see looking out over the whole time. Again, 2 important messages. The one message is these are patients that entered the study with imminent suicidal ideation. They all came through emergency rooms. They were all hospitalized. You could see rapid benefit of both treatments, but the esketamine plus the co-administered oral antidepressant having a benefit over the oral antidepressant alone. But you can see both treatments do pretty well over time in this severe group of patients with imminent suicidal ideation and behavior, maintained out over the month. And lastly, what are the mechanisms? And I'm coming right up to the end of the hour here, so I don't want to take too much time, except for saying there's good evidence to believe that the glutamatergic system still is very much at the center of these effects. And we think that it really is this rapid release of glutamate that is having the large effect in terms of activating neuroplastic changes that are allowing changes in the circuitry of the brain. However, there are other possible mechanisms, including effects on the monoaminergic system, neuroinflammation, and even some recent papers suggesting the opiate system, maybe not directly, but possibly indirectly, are having these effects. And then the non-specific effects, I don't think we can ignore. And I mentioned already that these very intense protocols have a lot of non-specific benefits to the treatment. The question always remains, how much is dissociation necessary? I think the jury's really out on that. I think the evidence is pretty clear that it's not a one-to-one correlation. There may be some effects. Some studies seem to show, at least for the first dose, but at later doses, not showing those same effects. But one of the most important pieces of data is from the rapid study where we looked at the multiple doses. And we can see that the 1 mg per kg really doubled the effect on dissociation, but clearly didn't have any significant improvement in the antidepressant effect. So it isn't more dissociation is better. That we're pretty clear about. Whether there is some threshold effect, I think we still have to determine that. But I think the real answer is it's complicated and not linear. There are several other drugs that are out in not for clinical use, but are in later phase clinical trials, and we'll be hearing a lot more about those in the next few months. And really, the take-home messages, I think you can read them and they'll be posted, but I think the main thing is there's clear evidence demonstrating that we now can generate rapid onset antidepressant effects. There is clear evidence that ketamine and now esketamine can generate these effects and can be sustained with repeated dosing. And it seems that they can be maintained. At least the esketamine has good data looking at safety over time, and I think we feel comfortable about that. There are still some questions that we have to answer about the longer-term safety for both of these, and also which specific subgroups are most likely to react, most likely to benefit, and also can this be used as a monotherapy? Really, those studies haven't been done, and definitely not to the level that should inform clinical use at this point. With that, I'd just like to wrap up and thank everybody collaborated on this. This is just a small list. And I think there may be 1 minute for questions.
First of all, Jerry, I want to thank you for an extraordinary presentation and for the work that you've been doing on this really very exciting new part of our treatment for people. I'm going to ask one question. We're over time, but we're going to go over time anyway. And the question is, how does somebody who may be listening right now, and either they or a loved one has had treatment with the traditional medicines, it hasn't worked, how do they know that they should consider treatment with ketamine or esketamine?
I think that really gets to the heart of what the presentation was meant to get at. What I try to tell patients is that this is not an easy treatment to do. So I get a lot of times people say, I'd like to try it. It works fast. I don't want to go through sort of the standard treatments. I think people neglect the fact that this is still a relatively new treatment, and it's a costly treatment, both in terms of dollars, but also in terms of time. So this is not something you want to jump to first line. Maybe in the future, if we understand a little bit more about how to use this drug more efficiently and safely, this may be something that we move toward. But at this point, you really want to make sure that you've given the standard antidepressants a good try. And in fact, the indication is for 2 failed trials of an antidepressant. And the other point is, the indication is for augmentation of an ongoing antidepressant. So right now, we don't have sufficient data of high quality to suggest that you could use ketamine by itself without an antidepressant. I look at this treatment as a third-line treatment. There are, I think, exceptions that we may have in the future. The idea that if somebody is imminently at risk for suicide, we may bump that up a little bit. If somebody is an inpatient and we really want to see if we can shorten that duration of illness or the severity as much as possible, there may be ways of using this. But at this point, it really is a treatment that should be used after attempts have been made with standard antidepressants.
Well, that's a very good answer. I think we've progressed because not too long ago, I think we would perhaps say about ketamine, it's something that has potential but isn't quite ready for prime time. And now I think we're saying that this is ready for prime time, but under certain circumstances that you just described, and down the road it may be ready for a broader range of circumstances. So there's a lot of promise with that.
I think there's tremendous promise, but I think the key words are to develop this in a responsible manner. We rational and responsible. This is something that could get away from us. There are real abuse potentials that we have to deal with. And it's not a treatment that doesn't have some acute side effects that really need to be monitored. So as long as this is done responsibly and rationally, I think we have a tremendous new breakthrough. I just want to make sure we stay on top of it.
Good. Well said. Once again, thank you very, very much. I also want to thank everybody who joined us for this webinar. All of the research we fund is made possible through private donations. So please consider making a contribution by visiting our website, bbrfoundation.org, or calling us at 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with family and friends, please visit the events and webinar page at our website. Finally, I hope you'll join us again next month when Dr. Suzanne Amari, Assistant Professor of Psychiatry at the University of Pittsburgh School of Medicine, will present the search for novel treatment targets for obsessive-compulsive disorder. This webinar will take place on Tuesday, June 11th at 2 p.m. Eastern Time. Once again, thank you for joining us and enjoy the rest of the day. Take care.